Thanks everyone for coming out. My mentors are Christine Curcio and Cynthia Owsley. We'll talk about the subretinal drusenoid deposits in the ALSTAR Cohort. I have no financial disclosures. Here's our financial support. Takeaway points. First, we're going to talk about a prevalence study. The takeaway point is that SDD is present not only in early and intermediate AMD eyes, but also in normal eyes. SDD is also a risk factor for development of early AMD. And early AMD eyes with SDD have slower dark adaptation, and this is largely attributed to the older age of eyes with SDD. And SDD in older eyes in normal macular health have no visual function evaluated in our study, and we'll talk more about these. So the purpose of the study, SDD, what are they? They're subretinal, not sub-RPE extracellular lesions. Unfortunately, they've been misclassified or omitted from grading systems based on color fundus photographs, and those also include genetic association studies. Our endpoints are the SDD frequency in normal and early and intermediate AMD. SDD is a risk factor for development of AMD, and association between visual function and SDD. In our sample is the ALSTAR Cohort, which are eyes in normal macular health and with early and intermediate AMD. Subretinal drusenoid deposits, also known as reticular pseudodrusen, have had many clinical names over the years, with en face views like with IR, color fundus photographs, autofluorescence. There's multiple names. You probably have heard of them referred as reticular pseudodrusen. With cross-sectional views obtained by spectral domain OCT, they've had the name subretinal drusenoid deposits. And these are different pictures that we'll discuss in just a little bit. Why the importance of reticular pseudodrusen? They confer risk. They're predictive of CNV. They're associated with a higher mortality. They're an independent risk factor for development of AMD. They're associated with type 3 CNV. They're found in GA, and they're found in other retinopathies affecting the retinoid system. There's different morphologies of SDD. You can see the histological slides here, and the yellow spots are delineating the SDD. They're dome-shaped with electron-dense caps, and these are more common in the fovea. They're also flame-shaped or meringue caps that are more common in the perifovea. They're often confluent, and they're septate-fasciculated apical processes. We recently submitted an ARVO abstract with Dr. Curcio that is aiming to delineate the histological stages of subretinal drusenoid deposits and of age-related macular degeneration, and the manuscript's in progress. Here is a full-thickness slice of the fovea and perifovea. You can see the yellow bracket is the retinal pigment epithelium. The teal bracket is the retinal layers, and you can see 1, 2, and 3 are the subretinal drusenoid deposits above the RPE yet below the retina. This is different from sub-RPE, which would be underneath the yellow bracket, which is more of our traditional drusen. Here are representative photos of SDD on en face color fundus photographs. You can see the yellow dots, yellow arrows here delineating the yellow small drusenoid appearance. This is IR, autofluorescence, and SDOCT. Note again the outer retinal layers. You can see the focal elevations of the ellipsoid zone and the subretinal drusenoid deposits above the RPE. There have been various clinical studies reporting the prevalence of reticular pseudodrusen or subretinal drusenoid deposits. Depending on the pathology that was present, whether it was normal eyes or those of AMD, or whether it was reported as the person level or eye level, had different varying levels of prevalence. You can note that for person level, the smallest prevalence was 3%, and the highest was 93.6%, noted with dry AMD with GA in at least one eye. And on the eye level, you see with 6% in non-AMD eyes and 100% in GA. So our data source, it's already been discussed, the ALSTAR Cohort, but it's a prospective cohort to address the question of whether rod-mediated dark adaptation in older adults and normal macular health at baseline precedes the development of incident AMD 3 years later. The patients were greater to or equal to 60 years old. The primary sample was 435 persons with grade 1, or also known as non-AMD eyes. And there was also an ancillary sample of 209 persons with greater than grade 1 with early and intermediate eyes. There were no late AMD eyes. Exclusion criteria was all other ocular disease except for refractive error and cataract. Imaging protocols performed at the baseline visit and then once again at a 3-year follow-up visit. So first we'll talk about SDD frequency in normal and early intermediate AMD eyes. For more information, the Department of Ophthalmology here at UAB recently published in Ophthalmology, so you can refer to the resource there. The methods, we image subjects using SD-OCT, not only of the macula, but also the peripapillary region of the optic nerve head. We use IR, fundus autofluorescence, and color fundus photographs. Eyes were assessed for AMD present severity using the AREDS 9-step scale. It was a cross-sectional study. There were 651 subjects enrolled in ALSTAR, and interestingly, it's from primary care ophthalmology clinics, not from retina-specific clinics. In order to grade whether SDD were present, we looked at image view, we looked at eye level view, and person level view. For each images, we developed a criteria for whether SDD was present and discernible, whether SDD was questionable, or SDD was not discernible. For the eye level view, SDD were considered present when one of the following criteria was met, that SDD was present in SD-OCT in at least one en-face imaging modality, or if it wasn't present in SD-OCT, it had to be present in at least 2 en-face imaging modalities. This incorporated the multimodal imaging technique that we employed. And on the person level, SDD was considered present if it was present in one or both eyes using both strict and expanded criteria. Also, I failed to mention in the eye level, the strict criteria was with SDD was present and discernible. We had an expanded criteria, was whether SDD was judged as either present and discernible or questionable on any imaging modality. So we had both a strict and an expanded criteria. The results of our prevalence study, the overall prevalence of SDD of all comers of early intermediate AMD and normal eyes was 32%. 62% had bilaterality. They were affected in both eyes. Persons with SDD were older than those without SDD by about 2 years. The prevalence of SDD was 23% in subjects without AMD and 52% in those with AMD. In early and intermediate AMD, the prevalence was 49% and 79% respectively, so higher prevalence in intermediate AMD versus less severe forms of AMD. After age adjustment, SDD was 3.4 times more likely to have AMD than those without SDD. And interestingly, using only color fundus photography, which a lot of times just the general ophthalmology clinics use, SDD detection per the AREDS protocol was only 2%, which notes the importance of the multimodal capabilities protocol and also the spectral domain cross-sectional analysis of the SDD lesions. And persons with SDD detectable by OCT and confirmed by greater than one en-face modality, 47% were detected exclusively on the optic nerve head SE-OCT volume, so on the peripapillary volume and not on the macular cube volume that we usually get for people with macular disease. This is a chart showing other demographics that we were trying to see were associated with SDD development. You can note that only age was clinically significant. Gender, race, education, smoking status, alcohol use, cardiovascular disease, high blood pressure, and statin use, we did not see any clinical significance. We also looked at various blood sample types, or blood tests like complement, ApoA, ApoB, and they were not found to be clinically significant. These are representative photos, IR, autofluorescence, and SD-OCT from the ALSTAR cohort of a patient with subretinal drusenoid deposits. You can see in the IR, and it correlates to the same lesion in the SD-OCT, which correlates to the same lesion in the autofluorescence. These are photos from the publication showing once again IR, color fundus photographs, and SD-OCT. This is an interesting photo in the sense that this was AREDS grade 1, so no AMD, but you can note in the SD-OCT lesion and very faintly in the IR lesion on higher magnification a subretinal drusenoid deposit. And then finally, here's a peripapillary region that notice in the yellow an a subretinal drusenoid deposit, and the cyan a basal laminar deposit. And we found quite a bit of SDD in the peripapillary region. Next, I'd like to switch gears and talk about SDD as a risk factor for development of AMD. For further resources, you can look at a publication from the UAB Department of Ophthalmology and IOVS that came out this year. We examined subjects enrolled in ALSTAR. We assessed the prevalence of SDD with multimodal imaging. 799 eyes from 455 participants were included, and they were classified with color fundus photographs using the 9-step AREDS classification system. And of note, AMD was defined as eyes having an AREDS grade greater or equal to 2 at 3-year follow-up. So anything early AMD or greater at the 3-year follow-up. Our results were as follows. 25 participants had SDD in one or both eyes at baseline. 11.9% of eyes in the sample developed AMD at a 3-year follow-up. And compared to eyes without SDD, those of SDD were 2.24 times more likely to have AMD at that follow-up. And after adjusting for age, C-reactive protein, and family history, the association persisted. And then finally, I'd like to talk about association with visual function and SDD. Manuscript is currently in progress or under review. AMD status for each eye was defined once again by the AREDS 9-step classification system based on color fundus photographs. We measured several visual functions, and those included best corrected photopic visual acuity, low luminance visual acuity, low luminance deficit that took the low luminance visual acuity and subtracted out the best corrected photopic visual acuity, contrast sensitivity, light sensitivity, and rod-mediated dark adaptation. And we once again used multimodal imaging in order to detect the SDD. The results were as follows. There are 1,202 eyes. 958 of those eyes were in normal macular health, and 244 had early AMD. In the normal eyes, SDD was not associated with any visual function evaluated. In eyes with early AMD, dark adaptation was delayed with eyes with SDD versus no SDD, about 4 minutes on average, but this dissociation diminished after age adjustment. And other visual functions were not associated with SDD in eyes with early AMD. This is the table from the paper that you can see. If you take all eyes, grouping in the normal eyes and those with early AMD, rod-mediated dark adaptation with age-adjusted p-value is 0.05, but if you look at them separated out with normal macular health versus early AMD, you can see that the clinical significance diminishes with those without AMD, and those eyes with early AMD, initially without age adjustment, it seemed clinically significant, but with age adjustment, that association diminished. So what are the conclusions of all these studies? So SDD are present in about 1/4 older adults with healthy macula, so no AREDS defined signs of age-related macular degeneration, and greater than 1/2 of persons with early to intermediate AMD. The prevalence of SDD is strongly associated with AMD presence and severity. It increases with age. And interestingly, SDD retinal topography, including its peripapillary involvement, resembles that of rod photoreceptors, which leads to hypothesis of deposit formation. For the incident AMD study, SDD in older eyes with normal macular health by the ARED scale is a risk factor for development of early AMD. So those eyes that were deemed normal based on our older classification systems, if they have signs of SDD, that are at a higher risk of developing early AMD, incidentally 3 years later. Older adults in seemingly normal macular health, yet with SDD, may warrant closer clinical monitoring given that possible onset of early AMD 3 years later. So we probably need to watch these people a little bit more closely. And for the visual function study, early AMD eyes with SDD had slower dark adaptation. However, this was largely attributed to older ages of eyes of SDD. It's known that the older age of eyes have delayed rod-mediated dark adaptation. And there were no other exhibited deficits in other visual functions monitored. In eyes in normal macular health, which these incidental SDD were not associated with any of our visual functions evaluated. What are our future directions? We plan on determining the frequency of the SDD in a 3-year follow-up of ALSTAR to see the temporal progression of these lesions. We're planning on describing the histological stages of subretinal drusenoid deposits. To examine the biogenesis of SDD and drusen, our hypothesis is that it's an outer retinal lipid recycling program issue. And then finally, discovery of genes associated with SDD in the ALSTAR cohort using comprehensive screening such as exome sequencing in cases and controls. So once again, our takeaway, SDD is present not only in early and intermediate AMD eyes, but also in normal eyes. This SDD in normal eyes is a risk factor for development of early AMD. And early AMD eyes with SDD have slower dark adaptation, but this was largely attributed to the older age of these eyes. And eyes with no macular pathology due to AMD with SDD showed no visual functions associated. Special thanks to Dr. Curcio, Owsley, and the whole team for this research project.